Have you ever encountered a patient struggling with frustrating symptoms of intermittent claudication? The telltale sign of peripheral arterial disease can often elude even the most seasoned clinician, leaving both patients and practitioners grappling with unanswered questions. But fear not, for in this video, we are about to unravel the mysteries of intermittent claudication, shedding light on its underlying cause, classification, diagnostic challenges, and the most importantly, the innovative solution that can transform the patient care. By the end of this video, you will emerge armed with the tools and insight to tackle intermittent claudication with confidence and clarity. Hello everyone, my name is Dr. Hazi Arifuddin and you are watching Medicos. So literally, claudio means I limp, yet the term claudication is used to describe the muscle pain due to accumulation of excessive P substance because of inadequate blood flow. Intermittent claudication occurs as a result of anaerobic metabolism and is classically described as debilitating cramp-like pain felt in the muscle that is first brought by walking, second not present on taking the first step, third it is relieved by rest in both standing or sitting position, usually within 5 minutes. Having seen the definition of intermittent claudication, we will proceed further. Intermittent claudication is not a diagnosis, but it is a symptom. When present, it is a rather specific and reliable indicator of arterial insufficiency of the leg. The distance that a patient is able to walk without stopping is called as claudication distance, which only reduces slightly from day to day. Some factors like excessive body weight, walking uphill, walking against the wind, and carrying load can adversely affect the claudication distance. The muscle group affected by claudication is classically one anatomical level below the level of arterial disease and is usually felt in the posterior calf, as the superficial femoral artery is the most commonly affected artery. In 70% of the cases, this artery is the culprit. Aortoiliac disease occurs in 30% of the cases, which may cause thigh or buttock claudication. Lyric syndrome is buttock claudication combined with sexual impotence, which is secondary to arterial insufficiency. This question is very commonly asked during your exams. Claudication is often a marker of silent coronary arterial disease. Similarly, 1/4 of the patient with claudication have significant atherosclerotic disease affecting their carotid and renal arterial system. The common modifiable risk factor for peripheral arterial disease mirror those for coronary artery disease. For example, smoking, diabetes mellitus, hypertension, and hyperlipidemia. Therefore, two main aims when treating the claudication are prevention of major cardiovascular morbidity through risk factor modification, and second one is the symptomatic relief or improvement. Now let's see about the Boyd's classification. Patient often complains that after walking a distance called as claudication distance, the pain starts. Sometimes if the patient continues to walk, the metabolites increase the muscle blood flow and that sweeps away the P substance which got accumulated. So because of the increased blood flow, the P substance get flushed away and the pain disappear. This is the grade 1 Boyd's classification. More often, the pain continues and the patient can still walk with efforts. This is categorized as grade 2, but mostly the pain compels the patient to take rest. This is grade 3. Claudication is not that common in the upper limb, but it can occur during writing or in upper limb exercises. Patients with claudication can present with either buttock or hip pain, thigh pain, calf pain, or even foot pain. These pain can occur either singly or in combination. The usual relationship between the pain location and corresponding anatomic site of arterial occlusive disease can be summarized as follows. Suppose the patient is having pain in the buttock and hip, then the involved vessel is aortoiliac. When the patient is having thigh claudication, aortoiliac or common femoral artery is involved. If the pain is in the upper 2/3 of the calf, then superficial femoral artery is involved. Whereas the lower 1/3 of the calf is involved when popliteal artery is having some occlusive disease. Foot claudication occur when the tibial or peroneal artery is involved. Let's see the buttock and hip claudication in depth. Patients with aortoiliac occlusive disease, that is the Lyric syndrome, may complain pain of the buttock, hip, or in some cases thigh claudication. Patients with aortoiliac occlusive disease, also called as Lyric syndrome, may complain the claudication in buttock, hip, or in some cases in the thigh region. The pain is often described as aching in the nature and it may be associated with weakness of hip or thigh while walking. Bilateral aortoiliac disease that is severe enough to cause symptoms almost always causes erectile dysfunction in men, causing impotence. Another diagnosis should therefore be entertained if the impotence is absent. On physical examination, there will be bilateral diminished or absent pulses at the level of the groin. There can be occasional bruit over the iliac or femoral arteries. Other finding includes muscle atrophy and slow wound healing in the leg. This vascular claudication is the true claudication, and it needs to be differentiated from the spinal claudication and neurogenic claudication, which are also termed as false claudication. It is worth mentioning here that nocturnal leg cramps that occur in older and informed patients are not associated with exercise. This complaint is thought to be neuromuscular rather than vascular in origin. Let's see the claudication in further detail. Claudication can be because of arterial, venous, and neurogenic cause. Let's see the differences among them. First, arterial claudication. This type of claudication is due to reduced blood flow to arteries, commonly caused by atherosclerosis. As blood vessels narrow, muscles receive less oxygen, leading to pain and cramping. Pain typically occurs after walking a certain distance because of the increased demand of the muscle. The pain resolves quickly, that is, within 5 to 10 minutes when the walking is stopped. This is very important. Peripheral pulses may be weak or absent. Pain is more intense when walking uphill or climbing stairs. Now let's see about the neurogenic claudication. Neurogenic claudication is also called as pseudoclaudication. Neurogenic claudication describes a pain syndrome due to lumbar neurospinal canal compression, which is usually due to osteophytic narrowing of neurospinal canal, thus compressing the nerves. Unlike true claudication, which occurs when walking and it is relieved by stopping, pseudoclaudication causes pain with erect posture and it is relieved by either sitting or lying down, that is, change in the position. Patient with pseudoclaudication may also find symptomatic relief by assuming certain postures like bending forward or sitting. It means it is positional. Pain may radiate from the lower back into the leg. Typically, pain stops almost immediately when the patient stops walking or take that particular position. Characteristically, the peripheral pulses are normal and pain is not related to vascular insufficiency but due to nerve compression. Now the third type of claudication is venous claudication. This is a rare type of claudication and it is associated with high venous pressure, usually due to the chronic pelvic venous obstruction or iliac vein thrombosis. Pain and cramping occur during walking just like arterial claudication, but it is not caused by the arterial blockage. There can be swelling or edema in the leg and that can be a secondary sign. Here, characteristically, resting for 20 to 30 minutes or by elevation of the leg, pain reduces. Peripheral pulses are typically normal. Symptoms may include varicose vein or other signs of venous insufficiency. A very close differential is osteoarthritis of knee or hip joint. In cases of osteoarthritis, pain in the hip or knee joints typically works in the morning or after a period of inactivity. Pain is felt while taking the first step. Osteoarthritic pain may not be relieved promptly after exercise. The pain is typically related to joint movement and not directly to walking or exercise. Unlike arterial or neurogenic claudication, osteoarthritis does not show vascular or neurological sign like altered pulses or nerve compression. Rest pain. As disease progression occurs, the claudication distance decreases and perfusion to leg may be so severely compromised that anaerobic respiration occurs even at rest, typically affecting the foot and calf region. The characteristic of the rest pain is that it is continuous ache. The pain is continuous and aching in nature. This pain seems to be due to ischemic changes in the somatic nerves. That is why it is also called as cry of dying nerves. Rest pain often intensifies at night, waking the patient from the sleep. This happens because during sleep, the heart rate slows down and the blood pressure can drop, leading to reduced blood flow to the extremities. In lying down position, there is no role of gravity, causes further hypoperfusion, which further decreases the oxygen supply to the nerves, causing intense pain. The pain is exacerbated by lying down or elevation of the foot because of the loss of gravitational effect on the perfusion pressure in the foot. It is very interesting that rest pain is relieved by hanging the leg below the level of the heart or sleeping in the chair or holding the foot reduces the pain slightly. That is why such type of patients, they may be seen in the wards sitting with the legs hanging, thus taking the advantage of the gravity. The affected areas, often the toes or forefoot, they become extremely sensitive, and even a light pressure or movement can intensify the pain. Analgesic may not be effective in controlling this type of pain. Now see another very important concept, that is critical limb ischemia. Critical limb ischemia is defined as persistently recurring ischemic rest pain requiring recurring analgesic for more than 2 weeks, or ulceration or gangrene of the foot or toes with a systolic ankle pressure of less than 30 mm of Hg or ABI less than 0.3. If you want to know more about the critical limb ischemia, then comment CLI in the comment section so that it will motivate me to make another video exclusively on critical limb ischemia. If you found this video helpful, then do press the like button, share it with your friends, and subscribe to my channel. Thank you very much.